Hello everyone, this is Amir, Hematology Registrar for the FRCPath Hematology session. Our today's session was about hemostasis cases, acquired von Willebrand syndrome, and heparin-induced thrombocytopenia. This is the summary discussion of the session for those who are not member of our FRCPath channel. The corrected answer is on the regular session that has been uploaded to the YouTube, and this is just a summary of the um, answer and about major mistakes. So, for all the new people who want to join our FRCPath channel and they are preparing for the FRCPath exams, they should know that um, we post 2 essays every week, and every week is a specific week. It is either a general week, transfusion week, or a hemostasis week. This week was a hemostasis week, and next week will be oncology. Questions will be posted on Sunday or Saturday evening. You need to send them on this email in Word document, before Thursday 9 a.m. No copy paste, please. Do not forward it in the WhatsApp message, forward it in the email. And feedback is given to the specific people. Write your initials on the answer. So the first question was about acquired von Willebrand syndrome, where a 71-year-old patient was under urology team for TURP procedure. Post procedure, the patient developed resistant hematuria, and now the team has contacted you for advice. They have given you coagulation screen which showed EPTT of 66 seconds, and the vitals of the patient were normal. So the first part of the question is asking you what is the likely impression. So the likely impression is acquired bleeding disorder. Do not say that this is acquired von Willebrand syndrome at this stage, because the information provided to you include history and basic tests which represent an acquired bleeding disorder, because this patient has no previous bleeding history. And they are asking you what further investigations are necessary to reach diagnosis. So when you are doing tests for acquired bleeding disorder, you're doing disease specific tests, and you are doing tests for the secondary causes of acquired bleeding disorders as well. So send the coagulation related blood test and the secondary causes like infection, cancer, etc. Um, I had shared the PDF of the acquired von Willebrand syndrome in the part 1 group. You should be knowing the secondary causes of acquired von Willebrand syndrome. Then in the second part, they give you further details about the case with von Willebrand screen and serum protein electrophoresis, which shows a monoclonal band of IgG 5.5 gram. Now they ask you what is the diagnosis. Now you can say this is acquired von Willebrand syndrome secondary to IgG MGUS. If you say this is acquired von Willebrand syndrome, this is half answer. If you say this is acquired von Willebrand syndrome secondary to MGUS, then this is a complete answer of your this part of the question. And it's different pathogenesis. So there are 5 or 6 different pathogenesis of acquired von Willebrand syndrome. You have to list all of them because it's a 6 marks question, so you can list all of them for your answer. Decreased production, inhibition, uh, tearing of the von Willebrand multimer adsorption, etc. Then few causes of the above conditions. So there are a lot of causes which can lead to acquired von Willebrand syndrome. It can be lymphoproliferative disorders, solid organ malignancies, drugs, autoimmune conditions. There are a lot. So you need to list them. Do not mention, do not write in description. Then discuss the management of the patient. This patient is bleeding, right? Give a heading of immediate management, assess your patient quickly, inform the patient what you are dealing with, and advise to remove antiplatelet anticoagulant from the drug chart and limit venesection, etc. Then mention the clinical history. Clinical history will be related to the bleeding and to the secondary causes. Then enumerate the investigations that you would like to do for the coagulation disorder and the secondary causes. Then consultation, explain to the patient what are the results of the available investigations, and what are you suspecting, and what you're gonna do now. Explain the treatment options to the patients, which are Vocento, IVIG, and Novo 7. And then mention follow-up of the patient as well, which is an important step in management of the patient. Do not jump to treatment directly in this question because it is asking you management. So you have to write the full management protocol. This is a 12-mark question. Okay. So assessment, consultation, treatment discussions, and the follow-up of the patient. And the second question was regarding HIT. Cardiology registrar contacted you about 70-year-old woman with a platelet count of 40 who had a recent cardiac surgery. Now, the question is asking you again, list the differential diagnosis. Just write the names of the differential diagnosis that you are thinking in this patient. It can be HIT, it can be sepsis induced, it can be hematinic induced, it can be drug induced, etc. And now it is asking you, what further history would you like to obtain to reach the diagnosis? So, if you know your list of differential diagnoses, you can ask the question according to it. If you have mentioned HIT, so you know what question you need to ask related to HIT or T-score. If you have mentioned sepsis as your differential, so ask about infection symptoms. If you have mentioned hematinic deficiency in your list, ask about um, hematinic deficiency related question. If you have mentioned drug related or transfusion related thrombocytopenia in your differentials, ask questions related to the transfusion, recent transfusion and medication history. Then pathogenesis of the most likely differential diagnosis is HIT. So type 2 HIT, write the type 2 HIT differential diagnosis. That there is interaction between PF4 and the uh, and it then convert into immunogens. Immunogens activate the immune system, and IgG complexes are formed and inactivate the cells of the immune system, and prothrombotic environment is formed. How make it simplified? Then different investigations to reach the diagnosis. Investigations for HIT and investigations for non-HIT causes. There are different screening tests for HIT, different confirmatory tests for the HIT. You are not required to write all the details of the HIT investigations. If you mention only the names, that is enough. Different anticoagulation options. So if you read the BSH guidelines, the recent one, it has mentioned different options now, other than argatroban and warfarin. You can use fondaparinux, you can use Duox now, you can use bivalirudin now. Some of the candidate has included IVIG and plasma exchange in this answer as well. They are asking you about different anticoagulation options. IVIG is not an anticoagulant. Plasma exchange is not an anticoagulant. If they ask you about different management options, then you can include IVIG and the plasma exchange. But if they are specifically asking you what different anticoagulation options should I use, then you have argatroban and warfarin, we know that. But now they have included fondaparinux and Duox and the um, bivalirudin. And then duration of the patient, because the patient has thrombosis. So BSH guideline says 3 months of anticoagulation, therapeutic anticoagulation for HIT patients with thrombosis, and 4 weeks, or if the platelet counts above reaches above 150, then you can stop anticoagulation for patients in HIT without thrombosis. Then what factors would you consider before planning anticoagulation? This is a routine question from all the hematology register. You receive calls from ASDAC, you receive calls from ambulatory care, from other departments. A patient has clot. Um, how should we start anticoagulation and what are the anticoagulation options? So, in general, we ask about the patient choices, organ function tests like renal function test, liver function test, body weight, etc. Any drug interaction, any allergies to medication, etc. This is HIT. In HIT, you cannot use low molecular weight heparin. You have an option of argatroban with bridging to. Uh, you have an option of argatroban, so you can ask about the renal functions. Um, If you open the argatroban protocol of your hospital, they would have mentioned different doses of argatroban according to the renal function. Okay. Check about uh, other medications on the list because after argatroban, this patient may be converted to DOACs or maybe converted to warfarin, and these have the potential to interact with the other medication. And patient choices and mention the duration to the patient as well, and specifically mention this is HIT, avoid heparin. So this was just a summary of our discussion today. As I mentioned, the during the session, I made some correction in one of the answer of the candidate, and it is on the regular session. You can check it from there. For the non-member candidate, we will upload our session on this website. And if you want to donate, you can use this link for donation. And if you want to become a channel member, you can use this link uh, to become a channel member. I know some countries have membership issues. Um, Sorry to say, I cannot do anything about it because the YouTube administration says that these countries do not have YouTube membership options. And why they do not have membership options, they don't know, and I don't know. That's why I upload the sessions to this website where you can you can listen to the session on demand. So next week is Oncology Week. I will be posting the uh, questions for the next week soon, and the instructions remain the same. Please follow the instruction. Thank you.